are delighted to welcome, we have 3 speakers representing 3 different organizations whose initiatives serving adults are improving access to care in Michiana. I'm going to go ahead and introduce our 3 speakers, and we'll let them go ahead and speak, and then we'll open it up to any questions once they are finished. So we have Baye Sylvester is the project coordinator and lead facilitator for Imani's long-running community support group, peer-to-peer and social justice advocate for all areas of harm reduction. Baye will speak about trauma-informed harm reduction outreach taking place at Imani Unidad. We have Kelli Liechty, is the Vice President of Access and Crisis Services at Oaklawn. Kelli will be sharing information about open access. And then we have Janee Carlile, is a project coordinator with Mental Health Awareness of Michiana, and we'll be discussing the Pro Bono Counseling Project. All right, I'm going to turn it over to you.
Okay. Good morning.
Good morning.
I find it very interesting to be here today, especially in light of the presentation from the keynote speakers. I think they spoke very well about self-healing communities. And I think that before I even say anything more about Imani Unidad, that self-healing communities is something that we all need to really embrace, learn more about, and be very intentional. When you come to Imani Unidad, to our organization, and I wear many hats in this community first and foremost, but as standing here for Imani Unidad, on the sign outside, the first thing you notice is a very deliberate quote that says that healing is a deliberate act. And I'll say that again, that healing is a deliberate act. We were very intentional, and a lot of thought went into that there, because our motto is real people, real needs, real power. And as an instrument in this community, Imani Unidad has been around now, going into, I think it's 19th year. And it originated out of a need in the Black community for the, for the most part, to educate the community about the ravages of HIV and AIDS at the time, because the information about prevention and self-care was not getting there. And a lot of folks was just kind of, well, that's not my problem type of attitude, which is still prevalent in a lot of communities today. Born from that, though, was the fact that this unique, very strong, little short woman named Deborah Stanley, when you come in contact with her, you found out that her interest was not just in protection from HIV, but she was a communities-based individual, and that's what drew me to her. And as an individual who stands before you with lived experience, in terms of street culture, in terms of alcohol and drug abuse and so on and so forth, and coming from an environment on the west side of Chicago, experiencing a lot of trauma, and being re-traumatized in many instances, I found myself uniquely attracted to Imani Unidad. So Imani Unidad, at this particular point, is reaching and serving our community, especially in terms of mental health and well-being, from the position of, we work by and large with Black and brown community, but we embrace everybody. We get referrals from probation, parole, people walk through the doors, and our approach is very much akin to what Velshana and Kim was talking about downstairs, and that is, we're very deliberate and we meet people where they're at. Now that is a cliche almost this day, because meeting people where they're at is hard when you have preconceived and stereotypical attitudes about who this person is. In the Black community, first and foremost, when you say that, I think maybe you should speak to a mental health professional. I ain't crazy. That goes way back. There's a lot of distrust there. There's a lot of distrust. There's a lot of implicit biases. There's a lot of explicit biases that people are right. They don't even know that they have these things. But we find it very, very, very welcoming to embrace these folks. We don't care if they're young mothers, if they're addicts, if they're professionals. We also, our peer-to-peer group has been going on now for 7 years. We've had over 600 people participate in peer-to-peer. I mean, from across the strata, we've had the mayor there, we've had individuals from the U.S. Attorney's Office come through there because they've heard about this peer-to-peer group and they want to know what's going on. It's not me that bring them. A lot of people say, well, why you run the peer-to-peer group? No, it's the collective. It's the fact that when you walk through that door, you know you have arrived at a space and a place to which all this trauma stuff, you can lay this stuff down. Now, I'm not being naive to think that someone is going to walk through the door and their whole life story is coming across like that. That's not intentional. But what you will find is that in our community, what we do, just like when we look at the black and brown community, we look at individuals, we're asset mapping with them. We are asset mapping because we know that everyone has strengths, everyone. But we know that in our effort to do so, that there are certain obstacles that we have to deal with. So who we are, peer-to-peer, is a diverse group of individuals based within the community who share a common purpose by uniting around common interests to address personal and systemic barriers. Recovery and reentry is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Now, that's saying a lot, but how do you actually do that? How do you actually do that? First and foremost is have that listening ear. Most of you all are professionals or soon to be professionals, and you hear this thing commonly, so well, you need to learn motivational interviewing. We need to learn, get back to listening, intentionally. Because most folks, I've come to find out, have a sense of what they need. They just don't know how to act on it. They don't know how to verbalize it. But through listening and getting those individuals to be comfortable enough to open up with you, to open up and share. And professional. Now, I can talk all day about the DSM-5 for you social scientists that's in here. I can talk about it. I can talk about the fact that I know that social science and stuff and mental health in and of itself, if we go back centuries, was for elite people. Those individuals who had the money. Poor people couldn't afford to see nobody. And the only time they came in contact with it was when it was a matter of criminal justice. Is he crazy or not? Should we burn him or should we not? You know, something like that. But it's what we have to work with. And in the hands of intentional people, in the hands of those individuals who are sensitive to the needs of people, it can work very well. It does work very well. So I'm not coming up here with no schism to trash anything, but I do want to say this here, that they talked about self-care. We all come into our professions with stereotypical ideas about this, that, or the other. And a lot of that there results in internalized ableism. Now, when I talk about internalized ableism, I'm talking about those things that I begin to believe that because you are this or you are that, then that makes me this or that. See, and we got to get away from those type of things. And so Imani Unidad, you know, we welcome the individuals, and what we do in our peer-to-peer group, we sit in a 360. And the reason why we sit like that, because there is no head of the group. I am only the custodian. Imani Unidad is the custodians of the group. And I don't care where you are, what you're working with, if it's tobacco cessation, if it's working with youth, if it's working with adults, in corrections or anything else. First and foremost, I think what would benefit us all is if we step into that space of another person and allow that person to feel our empathy for them. Because people who are in need, people who are in desperate situations, I remember when I was in my nonsense and folks used to stop me and say, you don't need to be doing that. You don't need to be doing this. I may have been hungry. My belly may have been touching my back. So I couldn't hear them. But when someone came and sat down and they told me, hey, can I be of assistance to you? Are you hungry? Are you this? Are you that? You got my attention now. And it didn't, you know, and over time, that's how we relate to people. We need to be relatable in terms of them, okay? So we also offer a women's group. This is called Catfish Fridays, okay? Catfish Friday is mostly about professional women who have to deal with the microaggressions in their environment. The microaggressions. I know quite a few women, personally, and some that sit here in this room right now, that has to deal with some of these microaggressions. And some of you think that because you have done what they said you need to do in terms of I've educated myself, I know I'm intentional, I have a good heart, but still, you may even have family members who feel that, oh, you ain't got to went to school, now you this, that, and the other. And all you try to do is just be true to yourself and help yourself. And this is very, very, very true amongst people who come from poverty. So we are now addressing that as well. So, you know, when I talk about our vision for the community, our vision for the community is that we are put in a position of trust. With our funders, and I'm also a recovery specialist, okay? I'm a recovery specialist with lived experience. So when I'm walking and talking with someone, I'm being very intentional about, I know that you have a story. I know that the first time that they picked up a cigarette, that they didn't say, oh yes, I can't wait to OD. I can't wait to be, you know, in prison, you know, and laying on or in the gutter, sleeping in an abandoned house. No, it doesn't happen like that. We all have a story, and I tell folks that the power is in the story. Someone may hear my story and it may not resonate, but you can get up here and talk about your experiences, and someone over here and say, yeah, she been living with me? You see what I'm saying? And so we have to think about this here. And when we talk about Imani Unidad and we talk about our efforts in this community, we want to ensure not just those individuals who come into our space as in crisis, we want to make sure that other individuals in our community who say that they are community leaders, that they are activists, that they are teachers, that they are pastors, and so on and so forth, we want to ensure that you are not re-traumatizing people because you haven't dealt with your stuff.
All right.
See? And this is very important. Because you have people in positions. I'm not talking about just elected officials or someone because they went to school and they got hired somewhere. We are who we are, but we do need to be mindful of the fact that if you're not working on your stuff, then you can become easily the part of the problem. Okay? And so we have worked with the city of South Bend and you know, they alive projects. We've educated and worked with different circles. We've done these things with other entities, organizations, trying to bring to them. Now they talk a lot about trauma, and many of us know about trauma, but what we don't talk about enough is historical trauma. What we don't talk about enough is historical trauma. And that's very real with people of color. Because, and you saw the word up there, and they talk about epigenetics for you neuroscience students in here, or anyone that know anything about it, and it gets passed on. And I'm gonna tell you something about epigenetics. I'm gonna give you the layman's version of it, okay? And that's this here, is that I go to work every day, I work hard, I come home, I pick the kids up. How you doing? How was school? I kiss them, I love them. Hey baby, how you doing? This and that there. It comes Friday and get paid. I get some oil in me. Y'all know what I'm talking about, right? Okay? And all of a sudden, I can't stand it. You know? And, hey, Dad. And I'm looking at you like, Dad, I don't even think you mind. All of this junk that comes forward, that's in the gene. That's the unresolved stuff of being told over and over and over again to get over it. They talked about it up there. Just deal with it. And women who have been through abusive relationships, I know you know what I'm talking about suppressing. You know, and we see people and we constantly trying to work with individuals in our community. I have so many people of color that come to me and they say, man, how come I can't get in drug court? Man, how come when I go to Oaklawn, you know, it's all a bunch of white therapists? Or how come when I try to speak my truth and the people next to me, there's an addict just like me, if they don't necessarily understand what I'm coming through, then all of a sudden, the therapist is not with me. That is why Imani exists. Not to say don't go, but to be able to articulate it in a way to help them understand where we coming from. I got 2 minutes. I want to say this here. On the front of these brochures, you'll see something. And it says, and it's very intentional. It says, when your mind is a weapon, you are never unarmed. To some of you might say, why did they put that on the front? But for some young child, and I call them children because that's what they are, who was frustrated, that misguided frustration, they need to hear that. They need to know that your mind is your weapon. Your mind is your way to escape from this nonsensical behavior that's going on. Because believe me, what is near to you is what is dear to you. My mother, my father. There may be more men running through the door than I can imagine. The food may be gone before the end of the month. But if that's the person that is nursing me when I'm sick, feeding me when I'm hungry, you can do all you can in school to tell me, hey, Bobby, you're good at this and that there. But I'm like, this is what's near to me. You see what I'm saying? That is what's near to me. And that's why Imani exists, is to give these folks hope, so that when they step through whomever door, they know that, okay, I know how to deal with, I know what to ask, I know what to listen for, and I know if I'm being treated fairly or not. And I know that we are being good, doing a good job at this here. Can we do better? Of course we can. Thank you all.
Thank you. We're gonna turn it over to Kelli. Okay. Is he gonna come?
Oh, there we go. Okay. Good morning, all. It's good to be here with you. My name is Kelli Liechty, and I'm the Vice President of Access and Crisis Services at Oaklawn. I'm really excited today to tell you about our open access platform. We have transformed access to services at Oaklawn in this bold and transformative way to say what we were doing before wasn't working, and we needed to do something better. At Oaklawn, we are the Community Mental Health Center. That means we are the safety net, and so we needed to do better to be accessible for those that needed services. So we went live in May with open access. What that means is that we have blocks of time designated on each of our campuses every day of the week where anyone can walk in and be seen. They'll meet with someone who will do the paperwork, open a chart, sign consent for treatment, do releases of information, all the paperwork pieces, and then they'll be seen by a master's level therapist who will talk with them, hear about what's going on, what's bringing them in today, and talk with them about recommendations for ongoing care. So that happens daily at each of our 3 campuses. We knew this was important because it's responsive to our communities and individuals when they need help. I think we've all worked with people, and you know that when someone picks up a phone to say, I need help, that's not when they need help, right? That may represent months, years of dealing with something, and they finally got to that piece of raising their hand and saying, I need something. And it wasn't okay for us to say, okay, we've got an appointment in 3 months, we'll get you in on Wednesday at 2 o'clock. That's not responsive. That's not hearing them, that's not giving hope. And so we needed to do better. So I'm excited to tell you a little bit about our journey today. Before open access, that's kind of how it was. You would call and talk with someone on the phone. They would complete some paperwork and open a chart, hear a little bit about what's going on, and they would schedule you on a clinician's schedule. We would reserve 2 hours of clinician time for that clinician to be able to meet with you, do an assessment, talk about what's going on, and then make a plan for follow-up. We triaged in between routine and urgent on that phone call, meaning that if you knew how to talk about it, right? If you knew what to say and you knew how to ask for it, you could probably get in sooner. But that was done over the phone. And so routine people were kind of pushed out as we made room, and we're kind of doing the best that we could. One of the biggest problems was that people only came to that assessment 50% of the time. Okay, so we are dedicating time with you on the phone and resources on the phone. we're saving 2 hours of a clinician's time. And it wasn't working for people, and we know that because only 50% of the time they were coming. It wasn't responsive to our community and how they needed to meet for help, to be seen, how they needed to work with their schedules. And so we were constantly kind of backed up because 50% of the time, a clinician was sitting there with 2 hours and no one there. So we moved to open access, which looks like my screen is just copied the same thing over. Sorry about that. Don't look at that second time. I'll tell you. I am sorry. To paint that picture, I want to tell a story though. As we were getting ready for open access, one of the things I did was went around to each of our therapy teams and sat in on assessments to learn from our therapists what they were doing, kind of look for some best practices, what was going well, what wasn't going well. And I will always remember this assessment. I sat in with a very experienced therapist, and someone came in, it was a young woman, and she told her story, and we both listened to her story. She had been waiting 4 to 5 months to be seen. There had been some different scheduling things where she had to cancel, but it resulted in this 4 to 5 month wait period. She had just had a baby, and she was experiencing depression, and she talked about, this woman was resilient and she was an advocate for herself. She talked about what she did while she was waiting for that appointment, was she just called different hotlines. She wasn't experiencing domestic violence, but she would call a domestic violence hotline. Or she wasn't suicidal, but she would call a hotline just for someone to talk to make it through that day. She was resourceful, right? She told me about all the different hotlines that she would just call. And I remember sitting there and I kind of wanted to like shake her and say, we're gonna do better. We're working on this. We're gonna do better for you. The first week of open access was crazy at Oaklawn. There was unmet demand and we had a lot of people show up, and so we were all hands on deck. So I did an assessment with a woman, and it was a very similar story, except she had just had a baby. She was maybe a couple weeks out. She was recognizing, I've had depression before and I feel like it's coming back on. I've got this baby now and I don't want to get to the place where I was before. And so I'm here. And she just walked in that day. She had an appointment coming up with her doctor, so we talked about what might it be a good conversation to have with her doctor to key her doctor in. Could her doctor start her on some medications at that appointment she had later that week? She was seen within 2 weeks for a follow-up therapy appointment. And to me, that is the picture of open access. And we know the impact, right? You think about that impact for that first mom and her baby of those months. You think about what that means. All you guys are in school, attachment. This mom struggling with this and what this might mean, as opposed to this mom who walks in and we say, yes, let's make a plan. We're here with you. And so that's what open access is. Don't read that. That's what open access is. When we talk about a continuum of service delivery, we are doing a lot of work at Oaklawn to talk about crisis and build crisis response. We knew that first we had to have a better way to access services, so that first we can prevent situations from becoming a crisis, and second, so that if someone is in crisis, we can link them to ongoing care. So that's why we started with open access. That is for people who are needing outpatient treatment in a low barrier way that is responsive to them and meets them when they're willing to come in to get help. As we think about the continuum of treatment, it's about what's appropriate and what does that person need in that moment. And this is honestly where some of our challenges are with open access, and I'll talk about that a little bit. Open access should be here, right? People whose symptoms are maybe mild to moderate, they're able to do daily activities. Maybe it's a struggle, but they're kind of getting through it. Without treatment though, those symptoms may worsen. And they can tolerate a waiting room and they're willing to seek treatment. Okay, that's the ideal sort of situation for open access, that they need outpatient care. Okay, they can come, maybe once a week. We do have more intensive services that are several times a week, but they are okay with outpatient care. They've got good support, they've got good resources. And then as we move up in impairments and symptoms, that's where you think about a mobile crisis team or a stabilization center or a hospitalization center. But open access is really for this lower level that are needing access to routine outpatient care. This process for us was an 18-month journey. We partnered with a national consultant to get to this place. We knew we couldn't just open our doors. We weren't ready for that, and some people, were like, you're crazy. So the things that we did is first we worked to increase engagement. Okay, so we wanted to learn from people coming to treatment, what made them more likely to come to an appointment. Because we had show rates that weren't very high, which is, you're likely to see. So again, we're reserving clinician time to meet with someone, and then, it's not working for them, so they're not coming. And so then we're getting, wait lists and backing up. So, we talked with clients about this and implemented scheduling guidelines, sent out different appointment reminders. And then we also hired engagement specialists, so that if someone doesn't come to an appointment, we're gonna reach out and give you a call and say, is there something going on? Is there something with transportation we can help with? What's going on in your life? We wanna make ourselves as accessible as possible. Can we talk with you about something that would help you get here? And so we implemented that. We also needed to increase our work process efficiency. So we trained all of our staff in collaborative documentation so that the note happens with the person while they're in the room. It's not, I meet with you and then after you leave, I'm gonna type all this stuff I think about what happened and how I'm interpreting that. We document this together. This is your record. So we're gonna talk about what we're typing, what we're working on, and then that also decreases the hey, I have to stay 2 hours after my day to do all my notes now, right? This is a collaborative effort. This is your record. So we're gonna type in here. I'm gonna let you know what this says. We're gonna type this together. And then we talked about maximizing treatment efficacy, and this is something we're still working on. So this is level of care guidelines. When someone comes in for treatment, we should be talking about right from the beginning how we're gonna be successful. When are you gonna know that you're doing better? What is that gonna look like for you? So it's not, hey, you're gonna be on my schedule once a month for here until eternity. It's we're gonna work together. We're gonna join in this. And what do you think it'll feel like to know that you're feeling better, and how can we start planning from that from the beginning? Here are some of the results from what we've seen. We started this in May. So we have completed 3,331 assessments for new people coming to Oaklawn. That has been a 65% increase for us in people coming in and being seen for assessments. Here you can see the breakdown of our community of what people are coming in for and needing. Substance use is huge in our community. And it's, we've got to all work together to keep that. Here are some of our, we're keeping track of sort of days of the week of when Wednesdays is our evening day, so we've got a lot of people coming in on Wednesdays. So this is at each of our campuses, typically on a day, how many individuals we're seeing. So the top here is South Bend, our South Bend campus. That's our busiest campus by far. So we're on average, about anywhere from 10 to 16 people are coming in a day to get seen and start services. Our time frames right now, this is something we're actively working on. Our average time from the time you walk in the door to the time you leave with some recommendations about what we plan together for ongoing treatment is 140 minutes. 38 of that minutes is spent doing the paperwork. That is something we are actively working with the state on, and how can we reduce the amount? That is a lot of time to complete paperwork. And when someone's coming to ask for help, that feels awful. For them to come in and weigh up, and some of that we're doing at the state level to reduce that, to talk about how can we make this more client friendly? This doesn't feel very trauma informed, and how can we reduce some of these redundancies? And then 69 minutes is the average amount of time they're spending with the therapist. Some of our successes is that we've seen an increase in engagement in treatment, and one of the ways we measure that is comparing the follow-up appointments with open access model as compared before. So we now see there's a 23% increase in people coming to that second appointment after this model. And again, I believe that's because it's responsive. It's when when they're coming and asking for help, we're able to meet them as opposed to like, months down the road. And so they're engaged at that moment. They've come in and there's hope and they're I want to feel better. Let's do this. And we've seen that. It feels really good to be responsive to individuals and the community. Like that story I told earlier, as well as community tragedies. I know for a fact that there have been numerous tragedies of shootings, deaths, murders in our community, where we have people that witness that, or where a loved one come in that very next day and walk in. You think about that from a trauma perspective of what that means, that they're getting support and we're joining with them right in that moment, as opposed to down the road where they've been trying to suck it up and deal with it and all those things are told, as opposed to thinking about how to do that differently. And that's really important. Recidivism, we have someone at our South Bend campus that her job is to work with individuals coming out of jail to bridge medication. So if they've been in jail and they've been on medication for a mental health need, she's able to give them a prescription when they come out to allow them to get established in the community. Since we've gone live with Open Access, she has done the same amount of prescriptions in the last 2 to 3 months than she did in the whole prior year. And so you think about what that means for a community and people coming out of jail and getting established in treatment and for recidivism. That, I don't know how to measure that, but it's exciting. And I think that's really great. We're not triaging anymore between routine and urgent, so anyone is walking in and being seen, and that's a better system for us. Some of the challenges, it's about ensuring the appropriate treatment level. Because the need is so high right now and everyone is struggling with staffing shortages and we don't have good crisis response systems, we are seeing people on that higher up walk in to be seen because they know they can be seen by a therapist that day, and that is challenging. So we're trying to staff efficiently, and then you have someone who is actively, having a psychotic episode or suicidal, and all of a sudden this therapist that thought they were going to spend an hour with someone is 3 hours in. And we know we've got to do work across the system to build better responses to crises so that this does work better. There's been huge culture change for Oaklawn and for our staff, and that is really, really hard. It's changed the way that they work. They used to have a scheduled appointment on their schedule. They knew a little bit about what to anticipate, and that doesn't happen anymore. They walk in and are there and listen, and that is really hard. And it's hard on a workforce that already feels tired and that is already short-staffed, so I wanted to leave that as well. Limited bilingual staff and diverse staff, that is something we're constantly working at. And then we need to respond with our ongoing delivery to meet the increase in need. Okay? It's all the time I was trying to get through. Sorry.
Janee, I'll turn it over to you.
Thanks. I'm really glad to be here and speaking with such a large group of people. I'm shocked how many people are here, but just to get a vibe of like what type of individuals are coming. Do we have people working at the hospitals? Few people, clinical, community health, okay, just community members looking for information? Research. Any counselors, therapists, okay? Students. So lots of different ways to internalize some of this information. But my name is Janee Carlile, and I'm the Pro Bono Counseling Project Coordinator for MHAM. So the goal of the Pro Bono Counseling Project is to improve access to mental health care for those who would not have access. So we've been talking a lot this morning about wait lists, people being uninsured or underinsured or not having the financial means to get behavioral health care. So the goal of Pro Bono Counseling Project is to make sure that those barriers are removed. So we offer counseling sessions for uninsured, underinsured, and people who are financially unable to meet those services. A little bit of the project background. We're still in our infancy in this area. We first piloted the program in 2020 and finished in July of 2021. And then it was officially announced to the community in September of 2021. We are trying to replicate it based off an Ohio and Maryland project, which have about 80 or so volunteer counselors and are really steeped in the community for about 20 years. So we're still in our infancy, we're growing kind of rapidly. I didn't realize I had the stats up there. Ohio has more than 70 clinicians, taking on at least one case per year. And then the Maryland has more than 650 clinicians and volunteers. So they're like very well staffed. They have lots of people on their staff. We're on a staff of one part-time. So we're working to get there for our community. So what we do primarily is offer the pro bono counseling at a short-term, no-cost brief counseling to all of our applicants. So what the application looks like for someone coming in from the community, they can hear about us through community members, they can hear about us through their primary care physician, any coaches that might be working with them if they feel like they need behavioral health, and they can fill out an application and we screen them. But when it's 12 short-term brief counseling sessions that are not for major mental health issues, but things like anxiety, transitions, depression, things like that. But a lot of folks that I see signing up or trying to get counseling services really just don't know where the resources are. So some of the applicants that I get are even like from Kentucky. They just Googled our name, they find it, they fill out an application, and they just need services. So the second thing that we do is just link them to the right resources. So even though we are linking them to a counselor if that's needed, sometimes they just need to know where to go next. And they're filling out an application, so like Kelly was saying too, they didn't know where to go and it was hard to make that first call. What's nice about our application, it is done online, so picking up the phone can be a little bit intimidating. And so I just link them with the resources that might be right for them. Maybe they already have insurance, but they're like, the waiting list is a year long. And I'm like, yeah, it is. But I can do that research for them and try to maybe get them connected with a group that might be going on in the community and just try to make sure, get them connected to Oaklawn, get them connected to other resources to make sure that they get that care. So again, like I said, it's short-term brief counseling, up to 12 sessions, which usually takes about 6 months. So some of our volunteers see 2 folks a year, some of our volunteers see 1. And it's counseling with a licensed mental health professional. So they can be licensed clinical social workers, licensed counselors, psychologists, family therapists. It's a licensed mental health professional. And it's at no cost to the client. So people sometimes don't know what pro bono means. They call and they're like, so is it a sliding scale? What do I need to pay? And we're like, no, it's at no cost to the client. And then just the referrals, connections to local agencies based on the needs. So something else that we've implemented recently is we have a lot of folks that we serve that are uninsured. And so we're linking them to an insurance navigator to make sure that they can have access to insurance based on their annual income. So we're just offering more services and not just connecting them with a licensed mental health professional and then sending them on their way, really servicing the care in that way. Some of our current stats for right now is we have 19 licensed mental health counselor volunteers. We provided 276 sessions since the pilot, and 48 clients have completed all of those 12 sessions in the time that we've been around. But in the last year, we've received 76 applications, but we've only served 31, so some of those people just weren't eligible. Either they were outside of our service area, they had insurance but didn't know where to go, they didn't want to be on a wait list for 2 years, so getting them hooked up with those types of services. We've provided 133 counseling sessions, connected 34 applicants to services outside of the Pro Bono Counseling Project that we keep track of just to make sure that we know where we're sending people to different therapeutic counseling centers or Oaklawn, and connecting them to the right place. And then the insurance navigator again, and making sure we're following up. So anyone that I refer out to the insurance navigator or to another outside of the Pro Bono Counseling Project, I always follow up. Hey, did you make your first appointment? So kind of like what Oaklawn is doing with that open access, is just making sure that they're getting the care that they need. And sometimes it can be scary, I don't do it for them, but just following up and getting that nudge and, hey, here's a phone call, or here's a phone number to call, and giving them that resource to do that on their own. So how the program works for the applicant, the client completes an application on our website. It takes maybe less than 5 minutes. It has some information about their address, or financial information, but not numbers, just like, hey, I'm able to pay for food each month, yes or no, like on a scale, just to get an idea of where they're spending their money. Eligibility is determined based on the application. I usually schedule a 5-minute phone call just to talk to them, understand what their needs are. Sometimes they don't fill out the whole application, so I like to just talk to them about what's going on. And then I match them with a licensed mental health professional when the time is ready. And they complete just a brief pre-therapy survey so that they can see what work they've done. So before they start therapy, and then they take a post-therapy survey as well, just to see the progress. Who is eligible for Pro Bono Counseling Project? Individuals, couples, and families who are residing in the Michiana area. So that means St. Joseph County, Elkhart County, and Marshall County. I had a lot of like LaGrange folks apply lately, which is interesting. I don't know how they're getting our information. They can still apply. I just get them services kind of like in the Napanee, Bremen, that whole area. I just try to get them hooked up with people in their area. So the types of issues that are addressed through the short-term brief counseling are things like relationship problems, life stressors, transitions, depression, anxiety, grief, loss, adjustments. And when I talk to these applicants on the phone, I do let them know that it is brief counseling, 12 sessions, and if it's something that, you know, like PTSD or something that they really need like a trauma therapist for, to refer them out to make sure that they're getting the care that they need. Who's not eligible? People who are under 18 years, so they can be 18 years of age, but 17 years of age and younger unless they're participating with family. Like I said, those who need more intensive services, and those who have Medicare or Medicaid. So also depending on the Medicare, Medicaid, a lot of folks don't take those insurances either, so I have to make sure that a lot of those organizations will meet the needs of the applicant. So I do make a lot of phone calls, do make a lot of referrals just to make sure that they have 2 or 3 phone numbers to call and get on their waiting list. And if that doesn't work, then of course I link them to the resources that they need. And just a quote based on one of our past clients. I was again blessed to be a part of the program. After each session, I was given or taught new tools to use to help in different situations. My relationship with my children, husband, and at work improved from the tools. I was able to cope with the loss of a loved one, accept, is that right? Is that even a word? Maybe medical aid, and become calmer and happier. The therapist was amazing, calm and understanding. So we give them an opportunity to give us feedback, and usually from the pre-therapy survey to the post-therapy survey, all of those 4-point questions, like I've improved on my mental health, I'm able to sleep better at night, they usually increase. And we also ask them, how many bad mental health days do you have had in the last 30 days? Average is like 15 before they start, and then after it's 7. So we are seeing a decrease in the bad mental health days that are self-reporting. So how can you help? So lots of different ways. You can refer clients to the project. We have the application on the website, so if you hear of anybody saying, I really need a counselor, I really would like to try therapy for the first time, I'm really scared, feel free to encourage them to just apply. And the application is on our website. And I did bring some cards up here too from our resource table if you guys want to take any of those. If you're licensed in the state of Indiana, you can volunteer. We ask that you volunteer 12 hours a year, so seeing 1 client. So if you're licensed and would like to volunteer for the project, we'd love to have you. And then we can also let us provide clients for your interns. So if you work in a private practice or working in an area that has licensed counselors, We have interns that are always looking for placements, and then they can take that pro bono client as well. And then I have my cards up here and our website as well for any information.
Thanks, Janee. Can we have the three of you maybe come up here, because we have about 10 minutes for questions, if anybody has any questions that they reserved, during the presentations. Yeah, we're gonna leave it here. Anybody has any questions, feel free to ask it at this point in time.
I have a question for Oaklawn. You mentioned that you have somebody on staff in South Bend to help with the recidivism, the people coming out of jail on medication and needing prescriptions, so that they can continue on that. Is there anybody in Elkhart or Goshen, Elkhart County that is doing that?
No, we don't have someone in that capacity right now.
Do you know if that's in the plan?
Yeah, I think we'd love to have that. I think some of that is coordination as well with the jail, and I think that, yeah, different places we're at with all those conversations, so I would love to have that same person, because I think it is a huge benefit, for sure, yeah.
Janee, so when somebody makes a referral to you, do you guys like reach back out to the referral source, and let them know that you found them help or counseling? How does that work?
It depends. If they ask me to, I definitely will. It just hasn't been on my radar to do that. Only if the applicant doesn't respond in like a week, I will reach out and just say, hey, I haven't heard from them. Did they have the right, my email address? Did they have the right link? But I can definitely work that in if that's important to the referral process.
I know for myself, cause I just made one, for a patient who had Medicare and Medicaid.
Okay.
And so I know that's kind of difficult finding somebody who will take both of those. I know Oaklawn does, but, just curious of how like the wait time and like.
Yeah, so right now, I guess I should have added that stat too. So I have like 7 people on the wait list right now. And just the way that it's rolling, it'll probably be 6 to 8 weeks until I can get people scheduled. So and that's typical right now from other organizations that I'm working with. Some of it's like 6 months. Do you know what your wait list time is?
It's a little bit better now.
Yeah.
I mean, we're probably maybe like 6 weeks right now, but in the past, it's been several months.
Yeah, and it kind of fluctuates. Like I didn't have anyone on my wait list 3 weeks ago.
That's a wait list to get seen by somebody or
Just
call
to get
them?
matched. No, I call them, when
okay.
someone fills out application, I call them within 72 hours,
Oh, okay,
just to make that first touch point.
okay.
And then if they are on the wait list, I always reach out once a month, just to say, you know, do you still wanna stay on the wait list? Has anything changed? Did you get hooked up with Insurance Navigator where you now have insurance and you need a new referral? So I just try to stay in touch with the people that do apply
Okay.
in that way.
Thank you.
Does that help?
When you're giving them the prescription after they come out of incarceration, are you ensuring that they have money to pay for those, or helping them in any way that way?
Yeah, we do, we have a foundation that, has a pool of money that they raise just for individuals, needing prescription, that aren't able to afford that. So, yeah, we have navigators at Oaklawn as well, so we would, you know, try to, see if the navigator can meet with them and get them on insurance, but we have resources as well as financial, they're able to pay for that, yeah.
One of the difficulties I've been finding people I work with is getting services for people who might be on the sex offender registry. Do any of your programs accept those folks? Because that's the difficulty that I have. No offense to Oaklawn, you guys are great. But
One
individual in particular was told he could not get services.
Yeah, no, we can't, and some of that is to do with our DCS contracts and just, it really is just, in terms of serving children and families and the safety we have to provide, so, we've had several people coming through open access, like, all the time.
I work with people with, various disabilities outside of employment.
Okay.
So they're referrals from vocational rehabilitation.
Sure.
And, yeah, we're always having difficulty with finding mental health services for people on the offender registry. You said you guys do work with-
Imani, has worked with those individuals, in an individual capacity,
Yeah.
because it's not, in our groups are adult. And so if they can't be around children, then that barrier is eliminated.
Yeah. And,
Yeah, and we don't ask those types of questions,
Okay.
so another question that also comes up is that, hey, I have a client who's undocumented. Can they also, so I've had, but I only know that because the referral source
yeah, they
reached out
put
to
it on
ask.
there, yeah.
We do not ask that, those
Okay.
types of questions.
Okay, so they would be able to go through you guys and get.
I would think so.
Yeah,
Right.
I think the important thing would just be when matching it.
When matching.
them is that the therapist has, that training and skills.
Okay.
Yeah.
And I'm not talking about getting treatment for their sex offense.
Right.
They have underlying mental health issues that actually led to them doing that,
Right.
unfortunately. But yeah, so it's good to know, thank you.
Yes, back there.
Just to help you, there is an organization that can work with those, that does work with those individuals you're talking about, and it's called Lincoln Therapeutic.
Why not? I know about Lincoln, I have a friend who's a counselor there, so. But, yeah, that's, if you go to Lincoln, you're on that, people know, you get labeled. You go to Lincoln, you're a sex offender.
Back there? Yep.
Okay, so I work with a family right now, and we recently went to open access at the South Bend campus, to get the child therapy, and we were informed that you guys only do group therapy for ages 5 and up, I think, right? So are you guys moving back to individual therapy like you had before, or like if group therapy is something that like the parents aren't exactly, I mean, I don't know yet, but like if they're uncomfortable with that, will you like refer them to someone to see an Elkhart, or how does that work?
Yeah, and that's kind of particular our South Bend campus just with staffing right now. So we have long wait lists for individual therapy for kids right now at our South Bend campus, but not for group. Yes, we are actively working to hire and recruit, so that's based on staffing. So they could, yeah, if they wanted to be seen at the Elkhart campus, they could, or we can make a referral to community partner for sure. Yep.
Can I piggyback off that? Is there an adult wait list for individual too?
At our, last I checked, there was 2 wait lists across our 9 therapy teams for individual therapy, so, and some of it is more dependent on if you have a specific need or a specific insurance type, not Medicaid or Medicare, but, private insurance is actually harder for us than, those, so, I don't know that off the top of my head, if there's a wait list for the adult team at South Bend right now.
Did you have a question?
Yeah, I actually have a few questions. So I work with a lot of individuals who suffer from substance use disorder, in particular crack cocaine. There's not a lot of medications out there to help with that addiction source. I know that there are a lot of intensive outpatient treatment resources, but what is being done for for that population, especially for our older individuals?
In terms of medications to help treat that, is that specifically what
Medications,
you're
I know that
asking?
they have, like I said, the outpatient, treatment, but I guess I'm running into a problem where I feel like, what other resources can I give these individuals? Because a lot of that is, like strength building, and giving them a lot of cognitive behavioral therapy resources and things like that, working with them on that. But what else is there being done?
I mean, I can tell you at Oaklawn, we have intensive outpatient therapy, and we have a couple different groups that work in intensive ways. So we have one for individuals who have like a dual diagnosis, meaning they have a substance use disorder as well as a mental health disorder. So we have intensive groups for that. We have groups for individuals that have trauma histories as well as substance use. So kind of coming at it more from that way as opposed to the specific, treating the specific drug of kind of what are the factors going on that led to the substance use. Is it tied to a different diagnosis as well? Is it tied to past trauma? We also use peer recovery coaches. We have a peer model as well, and have found. I mean, it is powerful. The lived experience. You can probably talk about that.
Well, when you speak specifically to crack cocaine, is pretty much akin to dealing with the effects of. It's the same lineage when you're dealing with someone with methamphetamine. It's important to get that person removed from the environment. So an inpatient stay quite often is the best jump off point for that outpatient, intensive outpatient to be successful. Because if they come in to open access and they get into our outpatient services, then if they're still in the immediate environment and they haven't had an opportunity to separate themselves and get a brain and their body a chance to start that healing process, which they would get if they went off to a 28-day program minimally, then that's in and of itself the best practice that I've seen as a recovery specialist. When I come in contact with someone, then that's what I want to do, is to get them inpatient first, and then when they're coming out, and then have that wraparound services, afforded them.
It's been really hard getting them into inpatient, especially those with Medicare. And so that's where, like, I get that completely, removing from the environment, but the thing is that then they go right back into that environment. So I guess I'm moved by that, because I really would like to see more work on that side, to see what can we do to help with that situation too. Because they are going right back into that environment, because that's where their housing is, and that's unfortunate. And so that's the only thing that I was just wondering if there's any like research being done, or have they noticed anything? Have you noticed anything, and what can we do to help?
Yeah, I think I would say I would notice that it is really hard to get inpatient treatment for substance use. Yeah, Medicare. I mean, I don't know of new places.
I want to say this here. I got to give it. Some of our recovery specialists stepped out of the room. We do have one still in the room from Oaklawn, but I believe that the recovery specialists who are on board, whether they're with the crisis team, the opioid response team, or with the drug court as I am, that we have a knack for getting people into places that other folks, if you pick up the phone, you might run into a problem, but we know the places. We have developed relationships with those on the other end of the phone that allow us to be able to overcome some of those barriers and get a person in. Now, on the flip side of that, when the person is returning, it's not just indicative to this community in terms of trying to find transitional housing for a person to help them while they're trying to stabilize. And a lot of that there has to do with the NIMBY, not in my backyard type of thing. And so we have to also address that stigmatization that's still attached to things, even though most of us are very close to somebody, who is struggling or has struggled or who have met their demise while they were struggling. And so we have to lend our voices to addressing that as well, if we're going to address that end of it.
Thank you.
Probably have time for like one more question, if anybody has one.
I was just gonna ask the question, you had mentioned undocumented. Are you able to help those that are undocumented?
We do not ask those questions.
Okay.
Yeah, because most of the referrals ask, do you ask for a social security number? Do you ask for a driver's license? We don't ask for any of that information. Just an address and a phone number and an email address typically.
But if they don't have social security number, for a fact that they.
We don't ask for it.
Oh, you don't?
Nope.
Okay.
Nope, so I wouldn't know.
We've had several individuals come through the doors of Oaklawn that's undocumented that we've been able to help. And the same can be said for Imani. I think that in the last 4 or 5 years, that collectively across the board, it's changed, and people are being welcomed in. That's a whole nother issue. We have people that's in drug court that are undocumented that, we work with, they need help. So it's just a matter of making that extra phone call. Yeah.
Where's Imani located? I
Imani-
don't know if you said that, but.
It's on the west side of town, catty corner from the Croc Center, most folks know the Croc Center, the Croc Center. It's where the, Women's Health Center used to be.
Okay.
If anyone is familiar with the old Women's Health Center, that was in that plaza. We're right next to St. Joe, Insurance. We're in the same building with them.
Is there a referral process that you do, or do they just show up?
They just show up.
Okay.
Yeah, they just show up. And as we get ready to close, I just wanna say this here. In terms of mental health, we have a lot of people who do a diagnosis, as you just mentioned, and they're still stuck in their behavior. And while they're still stuck in their behavior, then we have to have some capacity to be willing to embrace some aspects of harm reduction. You know, and so, understand that, utilize that, and if you don't wanna deal with it, then call Imani, because if we can keep them alive, then at some point, they may call her, they may call Oaklawn, you know? Yeah.
That's a great point.
Well, thank you, the three of you. Everybody at 11:15, if you wanna head down to the auditorium, the crisis panel will be speaking. Stop by the resource room and snacks or anything like that. Thank you.